Welcome, everyone. Today, I have the great pleasure to meet another direct care specialist, Dr. Jason Siegel. Thank you for joining us, Dr. Siegel, and welcome to the Direct Specialty Care Alliance webinars.
Oh, thank you. Thank you for having me. It's a really great opportunity. I've been a big fan of the group for at least a year now, so thank you.
So Dr. Siegel is a highly accomplished neurologist, and he is the founder of NeuroNow. This is a direct care specialty practice in neurology, of course, that is providing personalized care for his patients. Dr. Siegel earned his medical degree from Indiana University School of Medicine, and he completed his residency and fellowship training at Mayo Clinic in Florida. He is board certified in general neurology, brain injury medicine, and neurocritical care, and he has authored over 45 publications, book chapters, and he also has numerous lectures on topics on neurology, stroke, epilepsy, neurocritical care, and COVID-19. Dr. Siegel also earned a lot of awards, and he's also an active member of several professional organizations. He lives in Jacksonville, Florida, with his wife, Brianna, and 3 children. Dr. Siegel, welcome here. And we are very, very happy to have you and learn from you how you develop and how you run your telemedicine practice in neurology. But before we jump in, you telling us more about your practice, let me ask you something. How did you hear about direct care?
Yeah, so that journey started a little over a year ago, and I was kind of looking at what I was doing, and what I tell people is I'm a pretty simple person, and I was trying to think what's the most simple way I could practice neurology, and there aren't a lot of models out there for that, and so I really kind of Google searched. I found Dr. Joshi out in California, who's a neurologist as well. I was talking to him. He had pointed me toward the Direct Specialty Care Alliance group. And I really kind of dove in, reached out to you literally a year ago. I signed up for the online academy that you put together, which was instrumental in helping me kind of focus and think about things I need to think about. And then went from there. And really, it was the kind of model that I wanted to practice. Very, like I said, simple in the way that you can get rid of all of the distractions and just focus on the patient. And it sounds a little cliche, but that's really what it's all about, is trying to build relationships with patients. And the more distractions and other stuff you have going on, it just makes that relationship harder to build. And ultimately, I think that has adverse consequences on patient care. So it's been a very interesting, fun experience, and I haven't regretted it for a second.
I'm very, very excited to hear that you started your journey by talking to another direct specialist in our group, which was also very, very he was also giving his time to educate other people. And I'm also very happy to see that in 1 year or less than 1 year, you have a practice that is up and running, which is, many times unbelievable for many of the specialists that we talk to about starting a practice in direct care. Now, we know that you found out about direct care, but what made you choose direct care versus starting a traditional practice? What made you choose telemedicine compared to a practice that will see patients in office?
Yeah, so a part of that kind of goal for simplicity is decreasing overhead. As you said, I have a family, 3 young children. The thought of kind of diving into business loans, brick and mortar buildings, the cost of hiring staff to process insurance claims, the process of creating those contracts, honestly, it seemed a little overwhelming to me. And so I thought, okay, if I could, and as you mentioned, my practice is completely telemedicine, telehealth, teleneurology. If I could work from home, see patients in their home, bill them directly, man, that seemed to be as clean as I could make it. And I kind of think back way back in the day when doctors used to make house calls, and some still do, of course. But is this a modern version of the house call? And I think a lot of patients appreciate that and kind of can relate to that part of it. So really it was out of, I think, necessity of keeping overhead low, and out of the desire not to be overwhelmed and complicate things. So that's how I kind of got to this.
How do you decide to price your services?
Oh, that's a really good question. Honestly, it was creating an Excel file and just looking at other drug specialty care physicians of all sorts of different specialties, including neurology, rheumatology, and just seeing what they offered and how much they were they're charging. And so it's really just kind of comparing we're trying to get an understanding of what the market is out there. Some offer subscriptions, some don't. Some have other parts of their packages that I wouldn't have. For neurology, for example, some do Botox and things like that. And those are, I don't do that because I don't have, that office, or don't go to their house and do Botox. And then just really kind of pricing it and seeing, what the market, dictated. And so far it seems appropriate. I've been told by other, direct either primary care, specialty care, or kind of concierge kind of doctors, hey, you need to raise your prices. At the same time, there's, what is the market telling me? What is really the patient appetite for this sort of thing? I think right now, I like where I am. I think patients are liking where they are. I haven't had many issues there. So, but I guess to go back to answer your question, is just trying to compare as much as I can find online about other practitioners and what they offer and they charge.
Do you list your prices on the website?
Absolutely. In fact, the sub page on my website is transparent pricing. And there is everything that I offer. I have 3 different packages, from a subscription monthly to a kind of like a one-time visit, second opinion sort of thing. And they each come with different perks as you get obviously into the pricier ones. I think it's easy to understand. I haven't gotten many questions from patients. And yeah, it's all right there. I don't have any other hidden prices, fees, anything like that.
That is amazing. Now, because you mentioned about second opinions, and I know that there is a huge interest from patients to get a second opinion. Do you offer second opinions in your state, or let's start with that. Are you licensed in one state or multiple states?
I'm actually licensed in 9 states, Florida, Georgia, Pennsylvania, Indiana, Illinois, Iowa, Wisconsin, Minnesota, and Arizona.
Excellent. And do you offer these second opinions only in the states where you are licensed, or can you offer them in states where you are not licensed?
I believe it's just, I've only done in the states where I'm licensed.
Mm-hmm.
I don't know. Maybe you can tell me. Am I allowed to do them in the states I'm not licensed?
It's a big discussion and it's a big debate. It's a big debate, I would say. But in the states where you are licensed, you are legally able to give them a second opinion. Then, do you have many patients reaching out to you for a second opinion from those states?
Yeah, no. Most patients who reach out to me are more interested in a longer term relationship.
All right.
Probably the second opinions of the 3 different packages I offer is probably the least used or the least requested. But yeah, second opinions from Pennsylvania, Chicago. Yeah, so from the states that I'm licensed in. But yeah, patients generally want a longer relationship, and I think that's a reflection of the fact that people need neurologists, and to get into a neurologist, at least in Florida, and I imagine everywhere in the country, could be months and months. and they want somebody faster. And with this kind of model, we can have really good availability, very fast, very good access to us. And I think they're willing to, to pay out of pocket to get that. Yeah.
Of course. And because you are licensed in multiple states and you practice telemedicine, how do you market your practice in those states? What's your method? What's your secret?
Yeah, I don't have, when I strike gold, I'll let you know. Really the biggest source seems to be referrals from primary care doctors, particularly direct primary care doctors and concierge doctors. Those practices tend to have patients who are more familiar with this kind of model. And so really it's knocking on doors to primary care doctors. By that I mean calls, cold calling, emails, flyers, stuff like that, things to try to attract the attention of those sorts of physicians. We do have a presence on social media. We have gotten a number of patients who found us on Instagram, certainly through Google, and that's always interesting too. So we've tried Facebook ads, we've tried Google ads. That was very early on. We didn't get a lot of bites that way. That might be something we revisit now that we've grown a little bit, but it still seems to be kind of the bread and butter is direct referrals from primary care doctors.
So you basically identify who those physicians are in the states where you are licensed, and you go to them to market directly to them. Yeah,
more or less. It's, sometimes we just Google search, direct primary care Tampa, and see who pops up, and then we call, we email. I say we because my wife Brianna is right by my side every step of the way, and has been really instrumental in that part of it. Yeah.
So for those of you that do not know, the DPC community, they have a website called DPC Frontier, where you can identify the DPC practices in your area or in the states where you are licensed to reach out to them directly. Did you use that website?
I did, yeah. And I'm trying to think. We used that website. There are a couple other national organizations of either direct primary care groups or concierge groups. One is called ROAMD, ROAMD. And so I try to find those kind of societies, organizations, see what kind of listings they have. Some require that I become like a member essentially to have access. So we always kind of weigh the cost of those things. But yeah, always looking at new ways to try to attract new, I guess, primary care doctors to try to market to. Here in Jacksonville, there is actually a group of I think they started essentially as physical therapists. They're private practice physical therapists, and they got together, and they're also bringing together a lot of private practice physicians of all sorts. So I met a direct primary care physician through there that I didn't find online or on the internet. So just networking a lot. And I'll tell you, and I think my wife would agree with me, for somebody who's at the core introverted, that's sometimes hard to get out of my shell. But that's been an extremely important key part to this, is networking.
So that's an important piece. And I'm very glad that you mentioned that. If you want to practice and if you want to build a private practice, you have to communicate with others, and especially with others that are not physicians. So you have to get out of the doctor's lounge and meet people and connect with people and tell them what you are doing and why your services are good to be taken in consideration. Because you practice telemedicine, did you connect with the Chamber of Commerce close to you? Did you thought about that? Oh. Some people do that.
No, I did not. That's an interesting thought. What kind of benefits would be to doing something like that?
You're going to meet employers, and you're going to meet small employers that might need to minimize their cost for their patients, and they have a direct interest to send patients somewhere where the prices are reasonable and transparent.
That's a very good idea, and I'd be very happy to excited to hear other avenues, because that is something I've thought about. It's one thing to get one patient at a time, but to get a group of people, like from a company or something like that. Chamber of Commerce seems like, yeah, that's a good way to do that. Yeah. Yeah, okay, yeah,
The
good.
next question that I have is related to approach to patients that will call your practice and will ask you, because that's the first thing that it's going to happen. And when a patient finds you on Google, or when the patient finds a neurologist on Google or a rheumatologist on Google, they will call directly, not necessarily they will read about you. And the first question that you're going to get is, do you take insurance? How do you answer to this question?
Yeah, so I try to be proactive with that, actually. So when we get a call or an email, I reach out. I call them before I ever see a patient face to face, or through AV. I try to call them, and I always say there's two things about the practice you should know. One is it's completely teleneurology, and the second is that it's self pay. And so it's something that I don't try to hide. I just try to be very proactive. And then if during that phone call they had not realized that, I go through the details of that, and I'm just very honest. And yeah, there have been patients who said, well, geez, I really need, the insurance, or geez, I don't, know if I can swing that. Our model allows us to have some flexibility as well, which is nice, to work with patients on things like payments. And yeah, I'm sure I could have many more patients if I took insurance. But as we all know, that really limits a lot of what we can do in terms of that relationship we have with our patients. So I just try to be very upfront, very honest, and honestly very proactive about that, so there's no surprises when it comes time for the visit and the bill and stuff.
Because you're doing telemedicine, and billing is something that a lot of people struggle with, how do you bill the patients? Do you bill the patients up front? Do you bill a portion of that visit up front? Or do you bill everything after your visits? Can you explain to us your model of billing?
Yeah, so I essentially have three programs. One of them is a subscription. Essentially, I bill at the beginning of every month. If the first time I see them is halfway through a month, I prorate them, so I don't charge them the whole month. It's whatever left in the month. And then at the next month, it's the full amount. The other two are pay per visits, and I bill them when the visit's over and my note is done and sent to them. So there still might be tests that need to be done, MRIs that need to be done, those sorts of things. But when my note is essentially signed, I send them the invoice, and then they pay it. If there are, follow-up visits and things like that, they're billed according to, the pricing model that's on the website.
Do you collect their credit cards and then you bill them directly? Or for the membership, we understand that, but for the fee for service, how do you avoid not being paid? Because that happened to me, and I think it's going to happen to others as well, that patients, they come in, I was very, very sincere to them. I was telling them exactly the same things that you are saying. But then at the end of the visit, after I send them the bill, because I thought it's honorable to bill after you provide the service, the patients disappear and they don't reply emails. They don't pay their bills. How do you manage that kind of situation if you have a situation like that?
Yeah. I've been fortunate in that regard that I haven't had too much of that.
Neither do I.
Yeah,
I had
yeah.
just a few, but this is a question that many specialists will ask me. How do we avoid this kind of things?
Yeah, so I guess the first thing is to get an understanding of how common it is that really. My experience is that's not common at all. Yours
Exactly.
neither. And I would hope that, well, gosh, I'm just biased by my own experience, that probably wouldn't be for them either. Now, a couple of the safeguards. I do have in my patient consent contract that they have to sign, before a visit. There is language in there about if the bill has gone on for too long, essentially stopping their neurologist. So there is black and white where if they don't pay, they won't get any more service, and that's that. I don't send people to like collections and things. I don't even know how to do that, to be honest. So that's not really a part of it. But there have been a couple stragglers, and I send nice emails. The office sends nice emails. You need us to work with you on this and that, and unfortunately, I haven't had any issues. I will also say that in that same, I think under that same umbrella of what are patients going to take advantage of, for lack of a better term, a question I often get is, how often are you up at 3 a.m. getting phone calls from patients who have your personal cell phone number? And I would say, not really at all, and to be honest, if I get a text in the evening, I mean, it seems I'd rather just answer the text, get some stuff taken care of with the patient, maybe send a new med. Some of that stuff can be done so efficient that it doesn't bother me, and it prevents them a lot of times from then going to the emergency room for their acute migraine treatment and all those things on the back end. So I really haven't found that the patients that have my number abuse that at all or take advantage of that. I mean, it's just they seem to be very, very, very respectful, which I of course appreciate.
Yes, I have to admit that that's my situation as well. Patients are very respectful to my time. They rarely call after, 5 p.m. They rarely send messages. But if there is a message and I reply over the weekend or I reply over the Christmas time, because I had that situation, they are extremely appreciative, and they do understand that you are there for them when they need you. Because you are in direct care for about a year, can you tell me a story of one of your patients? How did they benefit from direct care?
So, yeah, I have a patient in northern Indiana with myasthenia gravis. She was going to have to wait for months to see a neurologist. She was seeing a neurologist in Indianapolis, which was several hours away from where she lives. She can't drive very well. And in her city, there are some good neurology practices. It was just going to be too long, especially because she was starting to have problems with her breathing. And as you might know, when myasthenia starts affecting your breathing, then we're talking about emergency room. We're potentially talking about intubation. I mean, just a whole lot of badness that could have happened over those next, whatever it was, 3 to 6 months before she could get in and see somebody locally. I was able to see her the same week as the referral was sent to me. We made some, honestly, really easy changes to her medicines. It wasn't anything that was like really earth-shattering, but it was enough that it helped her symptoms. She's able to go to physical therapy. She's doing some respiratory therapy. We still are working with, we started a immunomodulator. She was just on Mestinon, but we're starting some immunotherapy as well. All this stuff that, if she went on another 3 to 6 weeks, the first time I saw her, I was actually kind of worried about her. Again, nothing special that I did is probably, I would think, things that any other neurologist would do, but I was able to do it right away. She does send me portal messages very frequently. I like that. I want to know, how she's doing. I want to know her progress. I spent a lot of time in my past life in neurocritical care. I've seen what can happen with patients with myasthenia gravis going to respiratory failure, and so far so good with her. So that's the story that I often cite as an example, kind of a success story, not of me, but of this model of care.
I appreciate that you're saying that, because like you said, you think you didn't do much for her like others would have done, but you were there when she needed you. And I think that makes a huge difference for patients and for patient outcomes and for what's going to happen if they don't address it in time. And because of the traditional model, most of us, we are actually flooded with unnecessary consultations, or we are flooded with returns visits that are scheduled for a long time. I mean, not a long time, but they are scheduled to be there when the patient could answer, a few questions, and you can take care of that in 5 minutes. Or they come to your office because they need just refills on medication, which I always found really unethical to ask a patient to come to the office to refill the medication, but that was the way to bill. My experience is similar with yours. When you are there to serve the patient when they need it the most, they will forever remember that, and they will feel better, and you are basically save them from a bad experience, or from long hours to the emergency room, and long hours spent in the hospital, and huge bills. Now, I know that you can tell us more stories, but I would like you to tell us, what is your message for patients that are looking, or they want to understand the model, or they don't know why they have to pay cash, or they have to become self-pay to have access. So what is your message for the patients?
Yeah, I think kind of the high level view of it is that, and it sounds a little cliche, but the most important part of healthcare, I think, is the relationship a doctor has with the patient. That's, I think, the core of it. And I think that direct specialty care, this model, is the best way I've seen for that relationship to be strong and to flourish. And I think my patients would agree that's worth it. Once you start, say, processing insurance, now I have to hire people to process all those claims. Then my overhead goes up. Now I have to see more people, spend less time with the patients I have, and then all of a sudden, it turns into a 5-minute visit. No personal, connection. A lot of just check the boxes. Here's a medicine. And it's a trap that I think, so many physicians across the country fall into. But again, I think about it in simple terms, and is what's the best way for the patient and the physician to have a strong connection, the strong trust, and I think this is the model to do that.
Thank you. And the last question, because you are a physician that practices in direct care, what is your message for other physicians that are looking into direct specialty care, or a cash pay practice, or how many people think about this concierge practice? But basically, what is your message for those physicians that are looking into direct specialty care?
Don't be afraid. I'll tell you, when I made this transition away from a large academic, very large practice, large medical center, that is the message I got from a lot of my colleagues was, I wish I could do that, but it's so scary, and at least in my medical training, it was kind of assumed that you were going to work for a big academic institute or a big medical practice or a hospital system, that the ways of the private practice were dying, and then certainly nothing like this, and honestly, when people talked about like concierge medicine, it was almost looked down upon, like, oh, they're just catering to the super rich kind of stuff. And so then we all graduate medical school, we all go through training, and then we get jobs with those massive healthcare systems and everything. We we sign the non-compete clause and stuff, and it's scary. It's scary to think that we could leave that. There is a level of, I guess, security that they offer, but also, I think they take a little something away in terms of our, our autonomy and our ability that our feeling that we can do things on our own. And so I guess my message to doctors who are interested in doing something like this is to not be afraid that you don't get to where you are without having obviously diligence, intelligence, and bravery. You know what I mean? And again, I'm not saying that I'm a particularly brave person, but that's just what I heard from a lot of colleagues. Is it's just a lot of fear. Like they just, how could I possibly do that? How could I possibly leave this place? What am I going to do about it? My own health insurance? What am I going to, you can do it. Don't be afraid.
That's a very powerful message, and I want to thank you for doing that. In terms of building up a community for direct specialty or direct care specialists, do you think there is need for building up resources, a community for us, a map for us to exist, and also empowering other physicians to do it?
110%. Yeah. Again, like I said, there was no roadmap, for any of us, I think, to get into this kind of practice. The only reason I'm here, I mean, I can say this with full confidence that I'm doing what I'm doing, is because I found somebody like you and could model, my practice after that, and then see who else was in the organization and the alliance and see what they did. Oh, it's a tremendous, I mean, it's a necessity, in my opinion, to be able to network and to connect with each other. I mean, compared to the monstrosity that is the American healthcare system, it's a very small part. But it's again, a group of people who are very dedicated, who are very willing to help each other. And again, I think have all broken that wall of the fear, and now can kind of see the light and say, let's bound together, and help each other, ultimately to help the patients, obviously.
Thank you very much. So I have two people here. Dr. Yoshi, can you join us? And Dr. Moody. I think both
Yes.
of them being neurologists, and they might have questions for you, and I'm happy to let them ask you questions.
Yeah. Hey. Thanks, Diana. Yeah. Actually, me and Jason, we have talked a few times before. We are on a similar model, and my experience has been somewhat different. I don't have a membership plan now. I had it, and I tried to convince patients the benefits of it, but no one has signed up. So I kind of dropped that for now, and I will see how things go.
Can you tell us where you are located? Can you tell us a little bit about your practice? Is this an in-person practice, a telemedicine practice? Tell us a little bit about your practice.
Yeah. So I live in Winston-Salem, North Carolina.
Mm-hmm.
And I was with a big healthcare system, Novant Health, here till end of last year. And then for the same reasons that we all left that system, I also left, and I started telemedicine, neurology, direct care practice. And it has been growing slowly, but it still hasn't picked up yet to the point that I can rely on that. So I'm relying on other sources of practice. I have some work in stroke telemedicine in other states, and like a personal injury practice with another group in other state. But I think it will take some time, and I think I'm also starting physical presence now in Charlotte, which is like a 1-hour drive from my home. So I will be doing that probably once every other week or something. And in the meantime, let's see how this thing grows.
Do you believe in direct care?
Yes, I do, actually. It has advantages. I like it. You don't have to think about other like middleman, and you can just concentrate on patient care, and you don't have to spend like 15 minutes writing notes and all those diagnostic codes getting right and all that stuff. So I like it, and I um, I think I'll have more like I will enjoy it better when I have an in-person clinic. I think most of it will still be telemedicine, but this clinic will be for people who wants to see the doctor in person. So that will supplement my experience.
When
But I
did you
think
start your practice?
When
When did you start your practice?
I think about in October, November last year.
All right. So you are in the beginning of the practice. If I could say a few things, it's going to take a while, especially for specialists that we cannot offer all the preventative care. We cannot offer what primary care is offering. And I also had to supplement my income and to work a part-time job here and there. So it's absolutely needed when you begin the journey, especially if you want to compensate for the salary that you used to have. You have to supplement it with some side gigs, I would say. But it's doable in the long-term run. I'm 3.5 years into this, and it's becoming better and better. Once patients will understand what you're doing and other physicians will find out about you, like Jason was saying, reach out to them. And especially when you have a common patient, reach out to them, talk to them about the patient. They highly, highly appreciate that. And they will remember you the next time when they have a patient and you are needed.
Yeah, I think so. So as Jason was mentioning, I heard bits and pieces. I couldn't hear everything, but as he was saying that the marketing directly to the direct primary care doctor, that's what I have been doing, and some of the primary care doctors I have established good relationship.
Good.
So.
Good.
Most of them still haven't referred patients, maybe because they either don't need me or maybe the patient prefers an insurance doctor.
No, they do. It takes a while. So I can tell you that it takes a while. Offer them the possibility to do peer-to-peer consultations and build up on that kind of relationship first. And then when they need you for consultations, they can reach out to you.
Yeah, I see. The other thing, I don't know if Jason has similar experience, but like 80% or maybe more of the patients that I've been seeing they're not insured patients, so they don't have insurance to begin with, and I think they find my practice affordable, and they don't have they can't easily find a neurologist in the area and all that. So is that what Jason's experience is? Are most of the patients insured patients or not insured?
Most of them are insured. Yeah.
I see.
Yeah. So not all. Some are definitely in that same boat where they don't have it, and it's but by far most of them are insured. Yeah.
Okay. I can share from my experience. Most of my patients are insured, but they have high deductibles, and they prefer the cash pay versus the deductible. We have Yoshi here. Yoshi, do you want to ask something, comment something? You're a big part of this movement of bringing neurologists in the direct care.
Hey, sorry I joined late. This is Dr. Joshi. I think I spoke with Dr. Jason before, right? Over the phone?
Yeah. I cited you at the very beginning. Yep. That's right.
He cited your name at the beginning of this conversation.
Oh, great. How's everything going? You just started?
Back in August.
Oh, okay, nice. And I see another neurologist also started. He's in Florida, is you?
No, I'm in North Carolina. And nice talking to you.
Okay, good. Did I speak with you before as well, or I don't remember?
I don't think, no, we haven't talked. Where are
Okay,
you located?
I'm in physically in California. I started in lockdown when it was in March
Hmm,
2020 or
I
February
see.
2020. So I started in lockdown because my job was kind of, I mean, it was on hold for 2 months because of the lockdown. I was only outpatient, academic
Hmm.
neurologist. So I was just staying home and getting bored. So I just started telemedicine at that time. So it's still going. I'm not completely cash based. I would say I'm hybrid because I do take 5 PPOs. But
Okay.
eventually, in a year or two, I'm gonna get rid of them, and I do have a membership option. So, for Jason, though, I looked at the website briefly. Your pricing is uh, like pretty high. How is the patient reacting to it? Because when I had it that high, I wasn't getting too many.
Yeah, we kind of talked about that. I think good. In fact, I try to talk to the referring physicians, the semi patients, about the feedback and things. A lot of them are charging a lot more for their patients as primary care docs, and I think really only a couple times had a patient said, I just don't think that's affordable for me, and decided not to become a patient. Um, like I was saying earlier, I kind of try to let the market dictate and look at my growth month to month and to think, okay, could things be higher or lower? And this is where I've been here for a few months, and again, I think so far so good. So yeah, it's this is good that we're talking. It's good that we should continue talking because we're looking at a couple different case studies here. Even just the three of us. There's obviously not the numbers to really look at big scale what maybe is a good pricing for different communities and different states and stuff like that. But that's something we should continue, I think, sharing our information on. So that's interesting, though.
And I think
Right,
that the price should be thought as as a consequence of the demand that you have and what you can offer and the time that you spend with the patient. And the price is a big debate for a lot of people. And, as we discussed, we actually had a question at the beginning of this conversation about how to set up prices. And that's a question that I commonly get from other specialists. And it's very hard because you have to think about, not only how much money you want to make, but you also have to think of what you offer and what's your availability for those patients and what's your expertise that you offer to the patients, and also where you live, what kind of community you are serving. And based on that, you can come up with a price, and the price will change in time for sure. It did change for me and for everybody that I know. So you have to start somewhere. Your prices can fluctuate, but it's basically the demand that you're gonna have and the offer that you make.
right. Yeah, I guess at some point I decided like if I increase the price too much, the number of people goes down a little bit, but then those people are they're not poor, they're pretty, like a good, rich people, I guess. And then if I make it a little bit cheaper, I get the middle income families too. So that way the volume can go up a little bit, but the prices overall, it can little get cheaper.
I have to tell you that, that was my impression that I should lower the prices in the beginning, but I kind of changed that in time because you understand how much you offer, what is the expertise that you have behind you, and the fact that you are available for the patient when they need you. The accessibility to our practices is incredible compared to anything that I know. And patients will see that kind of value. And I have to tell you that, not everybody will appreciate what we are doing. So you have to I learned that I should be okay with that. But for those that appreciate, that makes me provide even more value and be there for them, and help them when they need it. So it's important, the price is important, but you also have to, or we all have to learn to value ourselves, because we are very bad about that. If you look at any contractors that you interact with, the people that will come to do, to repair electricity or to do anything for me, they know exactly the value of their services. We physicians do not know the value of our services. If you ask a lawyer, they immediately gonna tell you how much they charge per hour, and you accept it or not, that's it. But we physicians, we do not know to value ourselves, and we are also in this idea that we have to serve, and yes, we have to serve, but we also have to receive the recognition of that kind of service and the expertise that we offer to to the patients.
I'll take it even a step further and I don't want to speak for my fellow neurologists here, but I'm going to go ahead and stereotype us as a group of people. I think we tend to be a little bit more introverted and a little bit less, I guess, powerful personalities. And I think that might be even we might be a little bit more susceptible to undervaluing ourselves. It was definitely something I went back and forth with at the beginning, and to some extent still do. But it was a direct primary care doctor who told me the exact same thing. Don't undervalue yourself. What you're providing for these patients, and it will come. It will come. And so so I've kept the prices as they are on my website there, and haven't lowered them and things like that. And again, growth has been good. I think patients are happy, and I do think they're seeing that value. I'll also say, as I kind of said before, in this kind of model, it does allow us some flexibility. So if a patient's like, hey, I can't pay the full, say they're on the pay-per-visit program, I can't, I'm having trouble with this, whatever, we can work with them, you know what I mean? And it gives us a lot more flexibility to do things like that a lot easier.
Thank you so much.
Yeah, good to know. I think I agree with Jason, kind of. Yeah.
Kind of.
Yeah, the same. I mean, I'm probably in the same boat as you are. I'm hesitant to raise prices. So I just decided to give it some time, and maybe it will take a year or 2 years before I can make any changes.
Yeah, I think when I first made my changes, it was after first year. But then online marketing is a big thing, because if people don't know that you exist there, they won't be able to reach out to you. So I had to actually do the Google advertising for the first year. And then once you have the good Google presence, then people will find it easy.
Yeah, the Google, I had like a WebMD group doing ads for me on Google and Facebook and all that, and it doesn't work. The return on investment is so low. I think you just have to, you get a lot of phone calls, it gets you a lot of leads, they call it. But
leads do not mean conversion.
Yeah.
So we learned all about that. We will have to wrap it up. If you have any other questions, I will ask Jason to be kind to answer those directly, because we have to wrap it up. And I'm really, really happy that this discussion sparked other discussions. And that's the role of this kind of meetings and webinars. And I really want to take the opportunity to thank Dr. Siegel for being kind with his time to give us the time and tell us about his practice, about his experience in direct care. And I hope to meet him again in a year to tell us about the successful story of his practice.
Oh, thank you so much, Dr. Girnita. I really appreciate the offer and the opportunity. like I said, I've been a big fan of you and this group for over a year, and so it's really exciting for me to be able to be a part of it in this way. Thank you.